begins in 3, 2.
Hi, I'm Dr. Fox, and let's talk about the coronary arteries. In this video, we'll discuss the origin and pathways of the coronary arteries, as well as the pathways, branches, and tissues served by both the right coronary artery as well as the left coronary artery. We'll talk about heart dominance and its relevance to myocardial ischemia. So the coronary arteries are the only branches of the ascending aorta. In the cadaveric donor photograph, we can see the ascending aorta here, and we can see the RCA coming off of the right aortic sinus and the LCA coming off of the left aortic sinus. These aortic sinuses of Valsalva are the spaces distal to or superior to the cusps of the aortic valve. So we have a right sinus above the right cusp and a left sinus above the left cusp. We have a non-coronary sinus above the non-coronary or posterior cusp, but we only have two coronary arteries, one from the right and one from the left. These coronary arteries are going to travel along the coronary sulcus, and they will have branches that will jump out of the coronary sulcus and sometimes go into interventricular sulci and sometimes just travel along the surface of the heart. These vessels are found deep to the epicardium in the epicardial adipose tissue. It's important to also understand that the coronary arteries are going to fill during diastole. Keep in mind that during diastole, blood is going to rush back toward the heart, and we have those semilunar valves that are preventing blood from entering the heart. But in the case of the aortic valve, blood can then be diverted into the right and left coronary arteries instead. Let's take this coronary artery by coronary artery, branch by branch, and let's just start with the right coronary artery, or the RCA. So the RCA leaves the ascending aorta, and its first branch typically is called the SA nodal branch. Now this isn't rocket science, it's just anatomy, and so the SA nodal branch is going to serve the tissues around the SA node. This is going to be the case for 60% of individuals. For 40% of individuals, that SA nodal branch will arise from the LCA instead. Continuing on, that RCA goes down along the heart in the coronary sulcus, and its next most major branch is the right marginal branch. That right marginal branch is in close association with the inferior margin of the heart, or the inferior border of the heart, also known as the acute margin. That right marginal branch is going to serve the right ventricle, the walls of the right ventricle. And then if we move from this illustration to this other illustration, so here is the RCA coming down in that coronary sulcus, and right about there, it turns the corner and it heads towards the crux of the heart. Recalling the crux of the heart is where the coronary sulcus meets the posterior interventricular sulcus. And here at the crux, the RCA is going to give off two branches. There will be an AV nodal branch that is small and goes deep into the heart, and a posterior interventricular branch, also known as the posterior descending artery, the PDA for short, that runs along that posterior interventricular sulcus. The AV nodal branch supplies the tissues surrounding the AV node. The posterior interventricular branch, or the PDA, supplies the interventricular septum and walls of the ventricle. So this is the case in about 67%. So about 7 in 10 individuals the crux of the heart is supplied by the RCA. In the remaining percentage, the crux of the heart may be supplied by the RCA with the LCA or just the LCA, as we'll see. But let's take a look at what's happening with the LCA. The left coronary artery exits the ascending aorta. In 4 out of 10 people, there will be an SA nodal branch, but in most individuals, that LCA is going to quickly bifurcate into a circumflex branch and an anterior interventricular branch, also known as the left anterior descending artery, the LAD. That can be found in the interventricular sulcus there. So the anterior interventricular branch, or the LAD, is going to supply the interventricular septum. The circumflex branch is going to wrap around the heart, but before it does, it's going to give off the left marginal artery. That left marginal artery descends along the left border of the heart, supplying the left ventricle with blood. And at this point, we can pick that up right here on this other illustration, the circumflex branch wraps around the heart and it variably terminates. Sometimes it gets to the crux of the heart. In most cases, it does not. But that circumflex branch will continue to serve the left ventricle. Let's take a look at this donor cadaveric heart. We could rotate it around and show some of the portions to it. I'm going to tilt it like so. Here is the ascending aorta, and we can't see the origin of the RCA, but it's going to come out around there. And then there is the SA nodal branch going to the SA node, and the RCA is going to continue on down this way, and it will give rise to the right marginal branch, which serves the right ventricle along the inferior margin of the heart. So let me rotate that up so we get a better view. So there's the RCA, and then there is the right marginal branch. The RCA is going to continue along onto the diaphragmatic surface of the heart. So we continue our rotation, and we get to the region of the crux of the heart there. And here's the RCA coming along. Here's the posterior interventricular branch serving the interventricular septum. And here is the AV nodal branch serving the tissues surrounding the AV node. Let's go back to anatomical position, and we're going to rotate a little to the right and a little superiorly. And there's our LCA coming down. And there's our anterior interventricular branch. And it actually has 2 branches there. There's our circumflex branch coming around. And there's our left marginal artery. So anterior interventricular branch serving the interventricular septum, the left marginal artery serving the left ventricle. And we can rotate that around. And we can see that that circumflex branch peters out, and it never makes it to the crux of the heart. So it just continues to serve the left ventricle there. As we know, vessels are variable. We talked a little bit about the frequency of various branches arising from the RCA or the LCA. And we talked about the crux of the heart, where the coronary sulcus meets the posterior interventricular sulcus, and what that means for if the RCA or the LCA gets to that area. So there is a concept known as heart dominance, and heart dominance refers to the primary blood supply to the crux of the heart. And a heart may be right dominant, codominant, or left dominant. A right dominant heart is supplied by the RCA to the crux. A left dominant heart is supplied by the LCA to the crux. A codominant heart has both the RCA and the LCA supplying the crux of the heart. Now, this has particular significance with respect to outcomes when there's myocardial ischemia. If there is a reduced flow of blood to the crux of the heart, say via atherosclerosis or coronary artery disease, in an individual with left dominance, both their anterior interventricular branch and posterior interventricular branches, so both the anterior and the posterior branches, which is the entirety of the blood supply to the interventricular septum, could lose blood if there's an occlusion of the LCA. So in a left dominant heart, if there is a total occlusion of the LCA, you lose all blood supply to the interventricular septum. What can be found in the interventricular septum? Well, the bundle of His and the bundle branches. So you could knock out all of the blood supply to the myocardium that hosts the conductive pathway to the ventricles. In a right dominant heart, the posterior interventricular branch is from the RCA. The anterior interventricular branch is from the LCA. And so you have two sources of blood to the interventricular septum. So if there's any sort of myocardial ischemia through either the left or the right coronary artery, an individual still has some blood flow through the other artery. And so they're at a selective advantage for myocardial ischemia. Those that are codominant will have blood flow from both LCA and RCA, and they would have collateral blood flow and even more of an advantage in those cases. So heart dominance determined entirely by blood supply to the crux of the heart, and there are advantages in terms of myocardial ischemia to being either right or codominant, and there is a disadvantage to being left dominant. So we've discussed the origin and pathways of the coronary arteries, as well as the pathways, branches, and tissues served by both the RCA and the LCA. We've also talked about heart dominance and its relevance to myocardial ischemia. Thank you so much for your time, and I'll talk to you in the next video.